I am Rachel Warner. I'm the Executive Director of Penn's Leonard Davis Institute of Health Economics. We've moved our seminars to a virtual setting, as you can see, and we're focusing these seminars on the impact of the COVID-19 pandemic on health, healthcare delivery, and some of the other fallouts from this pandemic. Today, we'll be focusing on meeting the needs of vulnerable communities during the COVID pandemic, and we have an outstanding lineup of panelists who are joining us today. Going in alphabetical order, we'll start with you, Dennis.
I'm Dennis Culhane. I'm a faculty member at the School of Social Policy and Practice at Penn.
I'm Shreya Kangobi. I'm an associate professor of medicine at the University of Pennsylvania Perelman School of Medicine, and I'm the executive director of the Penn Center for Community Health Workers.
My name is Gina South. I'm a physician scientist and an assistant professor of emergency medicine at Penn and a researcher focused on the health impact of neighborhoods.
To start today's discussion, I'm going to actually start with a few slides to frame the discussion and to give a little bit of the flavor of how the COVID pandemic has been affecting vulnerable communities. And over the past few weeks, it has become increasingly apparent that COVID-19 is hitting some communities much harder than others. So this is, as you can see, is a map of Philadelphia. And here in Philadelphia, the neighborhoods with the highest rates of COVID-19 infections are predominantly Black. So the map that you're seeing on the left is a map of Philadelphia, and highlighted in red are the census tracts with the largest portion of Black residents. The map on the right shows rates of coronavirus infection by zip code, with the zip codes in the dark burgundy having the highest rates of COVID-19 infection, with more than 30% or more of the residents in those zip codes having an infection. And you can see, with one exception, which is up in the northeast of Philadelphia, up here, all of the areas that have the highest rates of COVID-19 infection are also the areas that have high percentages of minority patients. So all of these zip codes here and here are the same areas that have high rates of, in this case, Black patients. That phenomenon is not true in Philadelphia. It's true across the country. And here's another example from Chicago, where, again, on the left is a map of Chicago with neighborhoods with the highest rates of Black residents in red. In the middle is a map with rates of COVID-19 infection by zip codes in Chicago. And again, you can see that zip codes with the highest number of cases are predominantly Black neighborhoods. And this would also be true if we looked at rates of COVID by population. So it's not just that these zip codes may be densely populated, they actually have higher rates of COVID infection. And it's also true that Black residents in Chicago not only have higher rates of infection, but once they become infected are more likely to die from COVID-19. And the map on the right shows that mortality rates by zip code with the highest number of deaths in the predominantly Black zip codes. This phenomenon is, as I said, seen across the country. And what this bar graph shows is that if we look in state after state and city after city, we find that the rate of Black, in this case, Black residents in Illinois, for example, is shown here in turquoise at about 15%. The percentage of Blacks in Illinois who are infected with COVID is much higher than the rate of the population, closer to 30%. And the mortality rate is shown in dark blue, showing that the rates of mortality among Black Americans in Illinois is even higher. The question is, why are Black Americans and other vulnerable communities disproportionately being infected by COVID-19 and dying from COVID-19? There are a lot of possibilities, many of which our panelists will talk about today, but some of them may be higher rates of chronic conditions, limited access to medical care, and other health-related issues, including poverty, environmental pollution, segregation, and homelessness. I just wanted to leave you with one final image before we turn to our panelists, which was a graphic that was in the New York Times article, which was titled "Staying at Home During Coronavirus is a Luxury." This graphic shows the change from day to day in the movement of individuals among the wealthiest areas in the country, which are shown in blue, and the poorest areas in the country, which are shown in orange. By March 16th, which was the date that President Trump asked the country to stay at home to reduce the spread of the virus, those people living in the areas in the top percent of the income, which are shown in blue again, And the bottom 10% in orange were both moving less than usual. But people in the wealthiest areas had cut their movement nearly in half, whereas those people living in the poorest areas did not see a similar drop in their movement until later, about 3 days later, when they reached 50% of their movement. And even 2 weeks later, never reached the lower levels of movement that were seen among their wealthier counterparts. So with that, I'd like to turn to our panelists. So Gina, I wanted to start with you. Could you reflect a little bit on this, the figures that we just looked at showing higher rates of COVID-19 infection among Black Americans and among other communities as well, and tell us a little about your thoughts about why that happens?
I think it's important first to note that the racial disparities we're seeing here in COVID-19 really mirror many of the other racial disparities we see in other health outcomes. Like maternal morbidity and mortality, cancer rates and death, chronic disease rates. And so, these COVID disparities aren't really a surprise. When we think, you mentioned some of the reasons why we might be seeing them. So some of those really immediate reasons, like you said, higher rates of chronic disease. So in Philadelphia, for example, in some zip codes in West and Southwest Philadelphia, which are predominantly Black, up to 50% of adults have a diagnosis of hypertension. There are more challenges with social distancing, which I think is one of the things that's reflected on that last graph that you showed. And so, social distancing is a key way that we can protect ourselves and our families from getting this disease and from spreading it. But not everyone can do that the same. And so when you think about Black communities and even poor communities, you have a lot more multi-generational homes. So you have kids living with parents, grandparents, and even great-grandparents. So it's much harder to separate kids who may be asymptomatic carriers of the disease from the elderly who are going to be higher risk. You also may have more people living in smaller homes and smaller accommodations. When you look at who are our essential workers, so, doctors and nurses, yes, but many other essential workers are low-wage workers and are predominantly minorities. So think about food services, environmental services or custodial staff, trash collectors, grocery clerks, bus drivers. I saw one estimate recently that only 1 out of 5 Black workers is able to stay home right now. So it's harder to work from home. So you're going out. You're more likely to have to take public transportation, not have sick leave, et cetera. You mentioned some of the environmental factors. So there's some early evidence that living in a neighborhood with high levels of air pollution is associated with higher morbidity and mortality from COVID. And Black communities are more likely to be in areas with higher air pollution. And then think about populations like the homeless. Blacks make up 40% of the homeless population in the country. Blacks and Latinos make up 56% of the US prison population. And so, people who are in prison by definition cannot socially distance themselves. So we know all of these things, but really we need to dig deeper and ask why. So why do people living in certain neighborhoods have higher rates of chronic disease? Why is life expectancy so different at baseline? If you look at in Philadelphia, Society Hill, which is one of the richest neighborhoods in the city, has a life expectancy of about 88 years. If you go a few miles north to Strawberry Mansion, which is a much lower resource, one of the poorest neighborhoods in the city, there's a life expectancy of 68 years. That's a difference in 20 years within a few mile radius in one city. Why are Black communities more likely to be located in areas with high air pollution? Why are low-wage workers, who we have clearly deemed essential, who are vital to our functioning of everyday society, why are they paid so little? Why are they less likely to have health insurance and sick leave? And getting even further, why are our neighborhoods so segregated? Why are Black people overrepresented amongst the poor? And so you really need to dig deeper and ask why? And what you're going to arrive at is structural racism and structural and economic inequality. And so these are some of the very root causes of the disparities we're seeing in COVID, and more broadly the health disparities we see. And those are the things that need to be addressed in order to address all of these disparities.
Thank you. I want to pick up on one thing you said, and direct this to Dennis, which is that the rates of homelessness, as Gina said, are very high among Black Americans, and homelessness is a unique presents a unique challenge in the COVID epidemic. Could you tell us a little, Dennis, about some of the unique challenges that homeless people face, both structurally and related to their health?
Even prior to the COVID crisis, there were a couple emerging crises within homelessness that have occurred over the last half dozen, 10 years. Most recently on the West Coast, we've had a 72% increase in unsheltered homelessness just since 2014. So that's led to an explosion in the number of encampments. These are parts of the country where the percentage of people who are unsheltered runs from roughly 60 to 75% of the homeless population, compared to a place like Philadelphia, where we generally run from 5 to 10% of the homeless population is unsheltered, depending on time of year. So that's one thing that's been going along and creating some underlying risk associated with the unsanitary conditions and the lack of access to basic resources. The second is the aging of the homeless population, the second half of the baby boom generation. Very high rates of homelessness, even when they were in their 20s, predominantly African Americans, predominantly men who never got access to the labor market in the early 1980s and faced a lot of challenging circumstances. And it sort of intersected with the crack cocaine crisis, the war on poor people related to the drug markets and mass incarceration, addiction. So you have this whole brewing set of circumstances that displaced this generation for many years forward. And they now have a life expectancy of 64, to just tie into Gina's comment. We see in the adult homeless population health conditions that you would ordinarily see of people 15, 20 years later. So there's an accelerated aging process that effectively makes people who are homeless in their 50s elderly, and they have these comorbid conditions that are such a significant risk for hospitalization and acute care and death. For example, COPD. COPD rate in the general population, adult males 10%, in the homeless population it's 20 to 30%. And so there's a whole variety of health conditions that have accumulated across the life course, and of course the inequality, the racism that it's accumulated across these communities, across generations. So all of that sort of culminates in homelessness, and we can see strains of these various factors that are impacting the population.
And then Shreya, I want to just bring you into this conversation. You do a lot of work with communities and community organizations. Can you tell us a little bit about your thoughts about why we need to do a better job addressing not just the health of vulnerable populations, but also the communities that they live in and their resources?
To piggyback on what Gina and Dennis have said, we need to broaden the frame of this conversation. This is not just about COVID. COVID is a funhouse mirror that is amplifying issues that have existed forever. Decades ago, and we created a map of chronic disease and hospitalization rates across Philadelphia. It literally looked exactly like the map that you showed us at the start of the hour. People are not dying of COVID, they're dying of racism, of economic inequality, and it's not going to stop with COVID. There is a much, much bigger public health fallout that is happening as people lose their livelihoods, as they become socially isolated, as they defer preventive and health behavior. And so we need to not be surprised about this, not talk about this as a narrow COVID infectious response, because frankly, to echo Gina, there's no surprise there. The positive feedback loops between poverty and pandemics is very well established. What we need to do is talk about action. So my work is really about hiring those exact same individuals who are in disadvantaged circumstances or communities and who are natural helpers within those communities and putting them into systems, healthcare organizations, community-based organizations where they can effectively reach out and support individuals with a whole range of issues that may be affecting their health, the social determinants as well as the medical determinants. We've established this model. It's nationally scaled, and now we have pivoted it to this new world in which a lot of the support is even more critical than ever. And I think the real push right now is how can we reimburse these workers so that they are a part of the national response, not only to COVID, but of the wave of consequence.
I'm just going to pivot a little bit to thinking about the broader health context that you've talked about, and send the question back to Gina, which is that, over the years, there has been some things learned about how we can better address the structural racism and the causes of disparities in other health conditions. Are there lessons that we've learned that could be helpful in trying to contain the pandemic today, since we're talking about COVID?
A couple of things to think about. So one is we need accurate data. And this has been a call of a lot of people as sort of the racial data trickled out. We can't do anything if we don't have accurate data. And that should be really coordinated by the federal government, but also, state and local government need to make accurate data available to people. So A, we know what's going on, and B, we can start to do something about it. I think we also need to have focused task forces, if you will, focus groups of people who are going to specifically address certain structural issues, and recognizing, what those structural issues are. And so, for example, thinking about some of the issues with incarceration, we're seeing now we're seeing people released from jail early, a loosening of the amount of contact that people who are on probation have to have with their probation officers. And so can we even take lessons that we're learning now, things that we're doing now to protect people? Why can't we do some of those things afterwards and later?
Just to follow up on that with a question from David Barnes in the audience, who asked the question, is there any solid evidence about successful interventions that we can use to address the root causes of racism?
I'll give sort of 3 examples. One is something like a minimum wage. And so when you think about who our essential workers are, and the amount of money they make is generally very low. And so if you think about really a livable minimum wage that you can actually support a family on with having one job rather than having to work multiple jobs, things like paid sick leave and insurance, those get at some of those more structural causes. I'll give 2 other examples actually from my own work and from Shreya's work, but I've done work looking at blight remediation in the environment. And so thinking about the environmental impact of this sort of long-standing disinvestment in communities, we looked at a greening intervention and found reductions in crime, improvements in mental health, improvements in people feeling socially connected to each other. So that's an example of intervening not on people, but on places, and place-based interventions like that can have sort of a broad population level impact. And then I think Shreya's work that she referenced also is getting at some of those structural issues, because A, you're employing people who are the most knowledgeable of the issues that are faced in communities, and helping people really to address some of those social needs.
If we take a step back and look at the spectrum of the social determinants of health, it starts with this, intrinsic sins like xenophobia and greed, and those create structural racism, structural inequality that affects the distribution of wealth and resources and social position in society, which affects access to basic needs, and then that affects health behaviors, and that affects health. I think that we could answer the question of what evidence exists for interventions at each of those levels and stages. What I found really fascinating is that there's not a ton of evidence for interventions that act at the very font of this. And those would be empathy interventions, morality nudges, implicit bias interventions. There are some, but I do actually think we should have more conversations about what works to actually address racism, because that is the root cause of all of this, or economic inequality. Getting back to how community health workers, I think, can intervene across this spectrum, as Gina mentioned, I think quite early in that trajectory. We have developed some empathy interventions, for example, for medical students or even healthcare executives to be apprenticed to community health workers and actually go out with them into homes and communities and provide social assistance. And that in and of itself is an empathy intervention that actually we believe, and we have some research to suggest influences decision making and behavior. And you know, there are more concrete ways that community health workers can intervene on access to resources, behaviors, and then ultimately outcomes.
So Shreya, speaking of the work that you've done in communities that Gina was referencing, one of the, managing COVID in the community with community-based workers can obviously have a lot of benefits, which you've demonstrated very nicely, but there are also trade-offs in terms of the risk of infection, both of the community and community workers. And I wonder if you could talk a little bit about what those trade-offs are and how we might mitigate those risks in the community for the spread of this disease.
We've taken a pretty straightforward approach to balancing the trade-offs, which I'm glad that you mentioned, Rachel. I think in other countries and in some contexts, folks are encouraging community health workers to really be barefoot doctors, going door to door, doing in-person contact tracing, providing clinical symptom management. And we simply just do not feel that is appropriate. There's not enough PPE. The clinical guidelines are moving incredibly rapidly. And we've already kind of established at the first part of this conversation that this is much broader than COVID and will need to be addressed in a multifaceted way. So our community health workers, who traditionally are always in the streets and in homes and in communities, are currently safe in their homes. They are sheltering in place, and they are providing remote support, telephonic for those who don't have other modalities, but if possible, text, video chat. And they're, again, addressing the range. They're arranging for food delivery, helping people get unemployment benefits. They're organizing virtual dance parties. They're connecting people to crisis interventions. And they are reinforcing COVID public health messaging. So I think that there is a lot for this workforce to be able to do while we're social distancing. And then, of course, beyond that, it's going to just be absolutely critical.
Dennis, I want to return to the question of the COVID epidemic among the homeless for a minute. There have been some recent efforts through the federal government and through aid packages to try and address COVID among homeless populations. And for example, the Trump administration last week said that it was distributing $4 billion in the first round of aid to help homeless find emergency shelter and community expand testing and treatment. Can you talk a little bit about where you anticipate that money will go and how it will be used to have the biggest impact?
Almost every community that is facing this challenge, and all of the large and medium-sized cities in the country, have had to first turn to finding places to quarantine people who are homeless and positive. So the most common strategy has actually been to access vacant hotel rooms as the tourism and everything has declined under these shelter-in-place rules. There are a lot of vacant hotel rooms, and including here in Philadelphia, the city has master leased a hotel room in Center City. And so I think in Los Angeles, they've already rented about 9,000 rooms that they're available for quarantine, as well as for people who are at high risk. The other group that's being targeted are people who have particular vulnerabilities because of age or because of comorbidities, and they're being proactively isolated from the shelter population and where they can be recruited from the streets into these kind of accommodations. So it includes hotels, motels, particularly around quarantine, and some of those isolation beds are being put in larger facilities, so they could be arenas, gymnasiums, larger spaces that are congregate, that don't provide private rooms. And of course, there's always the risk about that because, even if there's social distancing, there's, a lot of shared use of bathrooms. They're in line for meals. They're in lines for all sorts of supplies all the time. But nevertheless, those are the two main target populations that the communities are using this $4 billion initially to work on. The encampment population is a little bit trickier. CDC has said not to break up encampments because it will separate people and they won't be able to access services, because sometimes there are outreach services and other health services that come directly to people at these encampments. So other resources that are putting in place hygiene stations, access to 24-hour bathrooms, because of course many people are homeless, use commercial stores and other places for bathroom access. And with everything being closed down, they don't have access to that. So basically, those are the main things that you're seeing, as well as, of course, testing. But there has been no actual federal strategy articulated about how often testing should be done in the homeless population, and how it should be coordinated. So unfortunately, that is looking pretty haphazard in different places. We had one shelter last week that did basically an epidemiologic study and tested everyone. It was a 600-bed shelter for men in Boston, and 200 people tested positive. So it was a 33% infection only, and there were about 35% were asymptomatic. So there is a lot of challenges facing the homeless population. I'll just make one last couple statistics, but we have about 200,000 shelter beds in the country which are fully occupied, most of which don't provide social distancing. They're often bunk beds, and usually by regulation, they're 2 to 3 feet apart. So part of the big challenge is, in order to provide social distancing in these facilities, we have to relocate half the beds, roughly, under our estimate, so that we don't have a net loss of those 200,000. Meanwhile, we have 300,000 people with no access to a shelter bed. The unsheltered population is bigger than the sheltered population. And so despite we estimate $14 billion a year that the U.S. spends on emergency shelter, we still have 300,000 people with no place to go to sleep. So we've got a lot of challenges, and the homeless population represents the place where all the safety net programs are failing in some fundamental way, and trying to really fundamentally address it is going to be a big challenge.
Thank you. It's a lot of big challenges we're facing. I'm going to take a couple audience questions here. There's one from Amaka Anayanya, who asked, unfortunately, areas of the country with the highest death rates also have implemented crisis resource allocation. How best can we ensure equity rationing decisions? Do we diversify crisis triage teams? How can we communicate this to the broader population as to not perpetuate historical trauma? Gina, I'm going to throw that one to you first.
I think this is actually an example of structural racism. And if we don't put that equity lens on rationing, we would miss that. And so, structural racism is when our public policies, our institutional practices, of which this is one of them, and other cultural representations, basically the world we live in works in various and reinforcing ways to perpetuate and worsen racial group inequities. And the thing that's tricky about it is that it's largely invisible. If you aren't looking for it, it's something that we often don't realize is happening. It's not something that a few individuals or institutions are practicing. It's something everyone is involved in. It's sort of baked into our social, economic, and political system. And so when we think about the rationing of care, so for example, if you have a policy where people who have more chronic conditions are going to be less likely to get the life-sustaining care they have because they may be sicker, well, who are the people who are having more chronic conditions who are sicker? We're already seeing that to be more likely to be Black. And so you are going to end up taking away needed resources sooner and quicker from our Black patients. So I think it is just important to have that equity lens on all of these questions we're having so that it's not missed. I love the idea of sort of a diversity sort of crisis response team or a team that specifically has an equity lens to make sure we're doing this all in a way that is fair and not harming people further.
A follow-up question to that, which Trey, maybe you could help with. It says, I'm New York City based and work with one of the companies that provides medical supplies and PPE. Resource allocations are mostly focused on large hospital systems versus smaller community hospitals who have higher caseload. How can we address this?
That is an excellent question, and I don't have the magic bullet, but I'll tell you one thing that we are trying to do is compile, a couple things. One is that we're hosting a series of national conversations focused on how community health workers can really be a critical part of the COVID and the beyond COVID response. And part of that discussion is focused on operational strategies for getting community health workers to be distributors of these essential supplies, including medical supplies, and having that channel open to disadvantaged communities. One of the eerie things that's happening right now is that hospitals are empty. Clinicians are not hearing actually as much as you would think about some of these social, economic, and access issues that are absolutely happening on the front lines. And what we're realizing is that it's a self-selection problem. If you're just thinking about, getting essential services and supplies through hospitals and doctors' offices, they're not plugged into the people who are really suffering the most. So I think it's absolutely critical to join community health workers and community health centers into that equation. And we are compiling those resources. I sent out a link to the webinars and to our website, so I would encourage folks to join.
I think one of the things, and Trey, you initially brought up that this isn't just a COVID issue, this is a healthcare and structural racism issue. One of the questions that's been posed is really for you, Dennis, which is about how can we, in all these steps we're taking to aid homeless populations, how can we think about extending them beyond the pandemic? And how can we ensure that this pandemic results in a positive movement for these communities so that they're not forgotten after the pandemic is passed?
A really good question, because this is something that communities are facing immediately. They have people coming out of hospitals who've gone through treatment and no longer need to be in the hospital. There are people who are finishing up quarantine, no longer need to be there. And so the question is, where are people supposed to go who've just gone through these experiences? Are we going to just return them to the streets? So do we have an exit strategy from these programs? I think that is very much at top of mind right now in folks working in this area. And the couple things people are thinking about is, number one, our disability insurance system is fundamentally broken. We would not have 50 to 60% of the adult homeless population have a disability and have zero income, unable to access SSI, for example, which is the basic safety net income for people who don't have access to Social Security. And so that is a very big issue. Is can we immediately make people presumptively eligible for SSI as a function of their having been either hospitalized or quarantined or even placed in one of these high-risk shelters? That would give people cash income. It could be supplemented with a rental allowance. New York City has a program like this for people who are HIV positive and become homeless. And it basically gives folks about $500 a month plus SSI, which they can then use with some case management help to find shared living arrangements, because they're not going to be able to find conventional, apartments on their own with that package. But many of these folks could find a shared living arrangement or a boarding home or other kind of living arrangement that would, get them out of homelessness. The other is basically federal housing subsidy, housing choice vouchers. The national advocacy groups in homelessness are asking in the fourth round of stimulus, they're asking for, I think it's a $3 billion addition to the housing choice voucher program that would get every one of these folks who are exiting these facilities a housing choice voucher to get out. So those are two opportunities that are being discussed, and which I think hopefully the pressure and immediacy of the moment is going to help us forge a solution of that nature.
We've had a couple of questions about the use of technology, and I think to sum up the questions and combine the questions, one question is how can we use technology and remote monitoring to better address some of these inequities? And another related question is it really possible to use things like telehealth to address inequities, since there are inequities in access to broadband and things like that? And so I wonder if any of you wanted to reflect, Shreya, if you wanted to start with that.
I'd love to, actually. I thought a lot about this. I think that, COVID has chased healthcare out of hospitals and clinics, and it will likely stay that way. And in some ways, that could be one of the positive legacies of this pandemic. But as yet, I think our focus, unsurprisingly, has been on the technology side, right? CMS was very swift to transform telehealth in 2 weeks. even though it had stalled for many years previously, and there's now reimbursement and liberalized restrictions. And so those who have internet, those who have smartphones can, chat with their doctor from their living room and all of these things. And yet that is only half of the solution. So 30% of Americans don't have broadband, 19% don't have a smartphone. As with everything else, those numbers will be skewed in lower income populations. And so if we just focus on telehealth, the Americans who have the greatest need will be left out of modern healthcare. Unless we have a workforce who is willing to initially, call people on the telephone. I think that is how we are getting through these initial weeks and months of social distancing, but eventually be able to meet people on porches and shelters and bedsides. We're not going to be reaching these individuals. And maybe even more broadly, unless we have that workforce who's going to bring healthcare into homes and communities and lives, the past era of the new era of healthcare is going to be just as expensive and siloed as the last. So I think we need to think broader than telehealth.
Gina, I wanted to return to you and talk a little bit about some of the work that you've done previously related to green spaces and the effect that has on health, which is very important. And I wonder if you could just reflect a little bit about how limited access to nature and green spaces among some communities has worsened the pandemic, and how we might think about how the disparities in access to green space can be addressed in terms of policy making and things like that in the post-pandemic world.
Yeah, so I have, always enjoyed walking around my neighborhood, going to our local community-run park, walking along the Delaware River. But those activities have taken on new meaning and importance for me and my own mental health in this last month. As an emergency medicine doctor, working on the front line, I have dealt with my own anxiety and stress. And so I have found when I go outside and spend time in nature that I'm immediately calmed. And there's a lot of literature and science to back that up, the mental health benefits of nature, and of course the physical health benefits. Unfortunately, a lot of public spaces are now closed. So in Philadelphia, for example, of all the parks and rec facilities, areas that are playgrounds, the rec centers, and basketball courts are all closed, while other spaces that are really more just nature and like sort of open nature remain open. And I'm actually looking at this now just to see the distribution of these spaces, but my hypothesis is that more spaces that are closed are in lower resource neighborhoods. And so, I think the other issue is that even when neighborhoods do have green space, it's not equitable green space. So an example is in Kensington. There is actually quite a beautiful area called McPherson Square. It's a full city block with trees and some benches and paths, but people that live in that neighborhood call it Needle Park. And because unfortunately, Kensington being sort of the epicenter of the opioid crisis in Philadelphia, it is a place where a lot of people use drugs. And so it's really not a green space that's available to the community to use in the way I might use my local park. So I think, the importance of public green space and open space is highlighted right now for just dealing with the stress and anxiety of what we are all sort of collectively going through. And my hope is that after this is over, I really would love to see more resources directed towards creating new green space and really restoring green space that already exists in minority and lower resource communities. An example of that in Belmont, which is a neighborhood near Penn in West Philadelphia, the Belmont CDC, led by a woman, Betty Ferguson, already actually has plans for what would be a beautiful community green space in what is currently a big vacant space. But they don't have the resources to realize that dream that they have as a community for this green space. And so we need more resources directed to community organizations and community groups that want to see green spaces in their neighborhoods.
There was a question from Pete Grunewald in the audience. Great Philly Inquirer article yesterday on the Kensington neighborhood, which Gina was just talking about. With all its challenges, surprisingly, rates of COVID-19 infection there have not been overwhelming. 58 positive cases per 23,000 in the population. Why aren't COVID-19 cases higher in Kensington And I wonder if you could reflect on when we see these neighborhoods that have lower rates than what we might expect based on the vulnerable patients, people who live there. What do we think of that? Is that an artifact, or is there something that, are there things people have done to reduce COVID rates in vulnerable populations that we could learn from?
I think it's too soon to tell. I'm with Gina. I mean, I think that the data will need to get better and it'll come. I'm, as you guys have probably realized on this call so far, a cynic. And so I think it's probably an artifact because hundreds of years of histories, again, have shown the same imprinting on these maps.
Another question that came in was that the current pandemic further highlights the importance of community services and social networks in wellness and recovery. How might we direct more funding and support to community-based organizations and businesses in addition to traditional healthcare settings?
I think that's really critical. We do often think about getting resources to community-based organizations, and I think that's super important. I do also want to say one of the things that has compelled me about community health workers is that they're not only community-based, they're not community-based organizations, they are community members. And there's a difference. You know, community-based organizations are still often, you know, led and comprised of somewhat self-selected people. You know, the individuals that Dennis is concerned with and that Gina's seeing in the emergency room are not the same people that are on the advisory boards or the executive boards of local community-based organizations. So, you know, one is I think we need to broaden the question to how do we get dollars to community people who are at greatest risk fast? And I think there is a clear opportunity moment here. I think that we should push for a couple of things. Number one, CMS has an interim final rule. There is a 60-day public comment period, and I would encourage everyone on this call to ask CMS to push for community health worker reimbursement as part of that. It has always been on the docket, much like a lot of telehealth that got stalled with bureaucracy, and this is the time to move it forward. This could also be in the fourth package that Congress is contemplating. 4 in 10 Americans are losing their jobs and their livelihoods right now, and community health workers could be onboarded as community health workers in a matter of weeks because that is a quick pipeline. And so we are really talking about a massive job creation pipeline, even as we stem a larger public health fallout.
Dennis, I wonder if you had any thoughts about how we could better use community services and social networks, particularly to the homeless population, to try and support them and address the issues that have been raised through this pandemic.
Sure. I think the one thing to keep in mind is that while it's, you know, a lot of us default quickly to the sort of stereotype of the visible homeless population, while we might have 500,000 adult homeless in the course of, you know, at a single day, actually 2 million people will experience homelessness at some point this year. So most of them are having relatively short episodes of homelessness. They maintain connections with their community. They have, oftentimes they're coming out of prison and they're having to resettle. They're maybe coming out of a treatment program and they need someplace to go, or there's family conflict. So there's a whole range of community-based services that have in some cases, and better than others, but helping people to reintegrate into the community and to stabilize their housing situations, whether it's with family members or with friends or partners, or even in, you know, finding new kind of board and care kind of arrangements that could be made accessible. So I think there's a lot of advocacy that could be done at a person level on behalf, because people are not be able to sort of make the connection themselves necessarily. The typical person doesn't know about these networks of services. To Shreya's point, mostly these are folks who are already plugged in many cases. So one of the reasons people are homeless is they're not able to access those networks. So I think in light especially of the economic downturn we're facing, it is an opportunity to infuse more resources in these communities, to do more specific, you know, person level advocacy that's helping connect this person with that resource or with that opportunity, because that one-on-one work, which we all know works clinically in healthcare, but in the social work and social welfare professions, the need is far greater than the supply. and it's a huge gap that's there, that so many connections that don't get made that could.
Gina, do you want to weigh in on that?
Yeah, I was going to say, when I think about community services and social networks and wellness and recovery, particularly in the Black community, I think about churches. And so, a pastor or a priest may be one of the most trusted sources of information for a lot of people. And so I think we can think more creatively about how to leverage, church networks in communities to make sure that our pastors and priests have the best information and the most up-to-date information to be able to share with their congregations.
And I was going to ask just a follow-up question related to getting sort of the sentiment that these organizations need to network together to provide support. And there's been a couple of questions about, I think, prompted in part by trying to care for homeless populations, but how that interfaces with the opioid epidemic, and that often some of the facilities in which housing homeless populations don't allow for treatment. And also how they can better interface with jails and prisons, so that when people are released from jails and prisons, particularly, there's been a increase in the number of people being released because of COVID, how they can better interface with these different organizations. So I wonder if maybe I'll start with you, Dennis, to talk about how you think about when you talk about advocacy for homeless populations, interfacing these different organizations together to best serve their needs.
Yeah, I think you've hit on a key point, which is that housing is actually sort of the fundamental problem across all of the populations that we might describe as vulnerable. Housing instability and lack of access to housing is a pretty common problem in these populations. And there was a recent study based on a program here in Philadelphia, Pathways to Housing. It's one of the first supported housing programs that targeted people with an opiate addiction and combined medically assisted therapy with the support services and a voucher, and had tremendously high success rates of people taking up the MAT, persisting with MAT, and being stable in their housing. So, and there have been other studies, of course, including here in Philadelphia, that show that if you clear the encampments in Kensington, but you don't provide housing, you don't have some place for people to go, you don't have MAT that combines with that housing, the outcomes are not very good. So, I think it does behoove us to be thinking about how to pair up housing resources, housing stabilization assistance or vouchers with these support services, because these vulnerable populations, we can't just look at them in isolation and think, oh, they need these services, because they don't always just need those services. They also almost always have a housing problem that coincides with that.
Shrey, did you want to weigh in on getting the idea of having community organizations, working together, obviously, to facilitate response in this case and in other health crises?
I agree with everything that was said. I definitely think that housing is an important lens. But one of the things that we found has been really a key success factor of the impact community health worker model is that our community health workers get to know patients' life stories, and then they ask each person, Mr. Jones, what do you think you need in order to improve your health? And so Mr. Jones can say, I need to figure out my housing and I need diabetic test strips. And Mrs. Smith can say, I just lost my mother to COVID and I need a reason to get out of bed in the morning. And then they create these tailored action plans and really kind of do what is needed for each patient. So I think that is the power grid for community-based organizations. I see community-based organizations as a lamppost, but community health workers as the power grid. They are the force that is kind of connecting each individual home into those, into the power grid and lighting everything up. And you really kind of need that individuality and tailoring.
So we've got about 5 minutes left, and I wanted to just end by asking each of you to answer the following question, which is: the federal government should play a key role in responding to this COVID pandemic, and they have the ability probably to do do things now that might make a difference 6 months or a year from now when we're coming out of the other end of the pandemic. And I wondered if each of you could just take a minute and reflect on what you think the best thing the federal government could do right now that would make a difference for these communities 6 months or 12 months down the road, as the pandemic is fading and as we're facing the ongoing health needs of these communities. Drea, do you want to go first?
Yeah, I'm simply going to underscore what I've said before. This pandemic won't fade because the pandemic isn't COVID, it's poverty. Even the COVID pandemic will likely have resurgence. And so the federal government, specifically CMS, needs to act to reimburse community health workers so that across the country, millions of unemployed Americans can be put into this workforce who can actually be on the ground, checking in on their neighbors and in their communities and addressing a range of economic, social, preventive health, and COVID prevention needs right now.
Dennis?
Sure. I guess if I was to pick a topic, I would focus on the income assistance. I think that, the safety net for income is woefully deficient. And, the three things I would see to work on there, one, as I mentioned, is SSI reform, making that program more accessible because we have aging and disabled people who are not getting into that program, who've been actually squeezed out with layers and layers of obstacles that have been put in place over the years and cuts in the program. So we need to make our disability insurance program work. The other is the unemployment insurance program. Only about 30 to 35% of people who are unemployed are eligible for unemployment insurance. One of the things we've seen under the recent recovery funding is that we're probably going to push closer to 75% of those folks would now be eligible. That's a great improvement. I hope that the long-term impact of that is that the unemployment insurance program does widen its scope to include contract workers, part-time workers, people who otherwise would not be eligible, but who, in a time of lost income, have no financial resource. And the last is our tax credit program, which, it works very successfully in helping very low-income and poor families with children to get $5,000 to $6,000 supplemental income each year and brings them up to the poverty level. In fact, it's the most important anti-poverty program we have for non-elderly people. But single adults don't get it, really. The maximum amount they're allowed to get is $500. And many people who are homeless or on the fringes of housing and labor markets, they're working. They show work effort. 45% of the homeless are working within a 3-month period of their homelessness. But they're not getting access to this tax credit program. So I think if we focused on the income insurance programs that we have that are supposed to help protect us from poverty, we could go a long way in helping a lot of these problems. Thank you.
Thank you. And Gina, you get the final word.
Awesome. So I want to see us, led by the federal government, have a real conversation about race and racism in this country. We have not reckoned as a country with this original sin, and now is the time to do it. So yes, these disparities have existed for a long time, but what's different now is that the only thing people are talking about is COVID. And so many people who have never even been exposed to this idea of racial disparities are seeing this for the first time. And so we need to have that conversation. Now, it's likely the federal government is not going to spur that conversation, but I encourage individuals, everyone can have these conversations on their own, with their family, with their friends, and let's get into the dirt. Let's have these hard conversations. I will say there are a lot of great books around this, but there's two that come to mind. One is How to Be an Anti-Racist, and the other is White Fragility. So I would highly recommend those to everyone. And let's actually try to change things around racism in this country.
All right. Well, thank you. I just want to take a minute and thank all three of our panelists. You guys were wonderful, and it was such a pleasure having you here today and learning from you. I also want to thank the audience for joining us and for the great questions that you gave us. We all certainly learned a lot and have a lot to think about. I want to take a moment just to remember to thank the frontline workers who are our friends and colleagues who are helping take care of patients and putting themselves in the line of COVID-19, and I hope that they can stay safe. And then just end by saying, I think, we all learned a lot today, but one of the things we learned is that it's a luxury to be able to stay home and protect ourselves from COVID-19. But it's also incredibly important to continue to social distance. So please continue to stay home. Everyone be well. Thanks for participating.